All this is Dr. Mobeen Sayed from drbean.com. Welcome to one more show. So, the discussion today we are going to do is the same discussion I just had with FLCCC. I thought I'll use the same uh, diagrams here as well. So, we're going to talk about the low dose naltrexone and its effect, especially on the immune system. So, let's start our discussion. After this talk, we'll also talk about the FDA and their approval for or request for authorization for the children. So, we'll do that next. So here, low dose naltrexone. Naltrexone is a molecule that blocks opioid receptors. And so it is used for helping patients who are addicted to alcohol or opioid drugs. So it is used somewhere between 50 milligram to 100 milligram per day. It changes for each person. Low dose naltrexone is something that was found in a study from zero point 0.5 milligram to 4.5 milligram per day. So that is about 10 times lesser or more or less. And it has shown to have a great immunomodulatory effect. It affects the immune system. So let's look at how does it affect that. The reason to look at that is the mechanism of action is because it is used in chronic diseases like fibromyalgia, in Hashimoto's thyroiditis, other autoimmune diseases, and for cancers as well, because it helps with the reduce the cell growth and so on. So it has immunomodulatory effect. And you would actually, once we go through the mechanism, I think you'll feel how magical this drug is and why it is used for chronic diseases. Nowadays, I believe it is very much applicable for long COVID like disease as well. So let's look at the mechanism. So this is not a medical advice. This is not a therapy for anyone. This is mechanism of action of a drug. It's a beautiful magical drug. Low dose naltrexone. It has two primary functions. One is the opioid receptor antagonist. Low dose naltrexone or naltrexone can be found in two molecular mirroring, levo or dextro. So that is the molecule structure is kind of mirror of each other. One of those structures works more on the opioid receptors and helps produce more endorphins. So what happens is when we block the opioid receptors with naltrexone, then the body tries to compensate, and then it, because of the blockade and the neurological system neurons that are stopped, other neurons become activated and we get more endorphins. Now endorphins are our natural painkillers. They are also something that would make us happy. So when you are they're called pain gate system as well, pain gating system as well. When you're playing games or when you are just having fun, endorphins are released. Not only they make you happy, but they also reduce the feeling of pain. They increase the threshold of pain. I remember I used to play squash a lot when I was in medical college. And sometimes when you're playing squash, and we used to be amateurs, and what would happen is somebody is behind you and they would just hit the ball, and instead of the ball hitting the wall, it would hit you. But during the game, you would not even feel that something happened. And that is because there are endorphins that are being released, and the endorphins reduce the sense of pain by gating the pain. Plus, they produce euphoria. You become happy. So even if you have pain, you say, whatever, I'm happy. So that is one side of it. In that area, low dose naltrexone has, so the that molecular image of the low dose naltrexone has receptors on immune system cells. So they're also kind of addicted to naltrexone to say, hey, we want some endorphins too. Although I'm just making it up, they have receptors for low dose naltrexone, and when naltrexone binds with them, it modulates their function and it helps them become optimal. So that is one side. The other side is the mirror image of this molecule can also directly work with the toll like receptors, and that is a mechanism I'm going to describe here. So toll like receptors or TLRs are receptors present on our mostly on our innate immune system. We know that the immune system is divided into two parts, innate and adaptive. Innate immune system has cells, for example, monocytes and macrophages and dendritic cells and neutrophils and NK cells and so on, mainly these cells. Low dose naltrexone works. So these cells, dendritic cells and macrophages, they have little things on them which are called toll like receptors. These receptors function is to, so imagine this, there is a big macrophage that is running around, that is going in a street, and it has those little tentacles coming out of it. These are toll like receptors, and whoever is passing nearby, it is kind of touching them. And if they are a virus or a bacteria or a fungus, it will recognize them and eat them up and try to clear them and try to activate the immune system against them. Secondly, when our cell gets damaged, so let's say there is a virus and that virus comes in and goes into a cell and it damages the cell, the broken cell pieces, the damage, also activates the toll like receptors. These are called damage associated molecular pattern recognition receptors. So these receptors can actually see that there is a broken cell here. For example, a broken cell would release mitochondria and mitochondrial DNA from it. Our immune system has never seen a mitochondria before because mitochondria always live inside the cell, never goes out in the streets, that is outside of a cell. So our immune system actually do not know about mitochondria and its DNA. But when a cell breaks down and the mitochondria are exposed and they're ruptured and they're broken and their DNA comes out, that DNA can cause the toll-like receptors to become activated. Similarly, there are many other parts within the cell, many other proteins, many other structures that when they spill out, for example, DNAs and RNAs, our immune system will become active and say, what the heck is this? And I'm going to become active and I'm going to react. So the short of this so far is the following. Immune system has toll-like receptor, innate cells. Those receptors can be activated by an antigen, pathogen, or broken cells. Good. Second part of this discussion, once the cell, the immune system cell becomes active, becomes aware that there is a pathogen or there's a broken cell, then what does this cell do? This cell, in turn, starts producing chemical substances. We have done this talk that interleukin 1 and interleukin 2 and interleukin 8 and 6 and 10 and 12 and so many. Tumor necrosis factor, granulocyte monocyte colony stimulating factor, GM-CSF, and so on. So there are a bunch of interleukins and chemical substances that are released by this cell, which it is doing to activate the immune system. One of those components is interleukin 6. And why we just want to talk about interleukin 6 today? Because low dose naltrexone works on these immune cells and asks them to reduce the production of interleukin 6. Do you know this is a similar mechanism like tocilizumab? Tocilizumab's function is to block interleukin 6 receptors. Here you are going to see a drug that can actually do the same thing. It doesn't block the receptors, it actually blocks the production of interleukin 6. Beautiful mechanism. I love it. This drug, if it was a thing, I would hug it. So now what does interleukin 6 do? So now we're not talking about the drug, we're talking about the molecule that this drug reduces. So let's look at the damage by this molecule. Now remember, interleukin 6 is actually a good thing. It helps us during the fight and war with the pathogens. It helps us during the inflammation. But sometimes these cells go mad and they cannot become corrected and they cannot stop and they keep producing interleukin 6. And now we have chronic inflammation and we have chronic diseases. And LDN is going to help break that cycle. This is why it is used in many chronic diseases, many chronic illnesses. So let's see. Interleukin 6, one function. When interleukin 6 is released, imagine let's use SARS-CoV-2, that is the prevalent infection nowadays. SARS-CoV-2, let's say that I have infection in my throat, SARS-CoV-2, that caused my innate arm over here, macrophages or dendritic cells or monocytes, to produce interleukin 6. That interleukin 6 is now going to travel in the blood and go to bone marrow. When it goes to bone marrow, it causes the bone marrow to make more platelets. Platelets, we know, are the tiny little anucleated cells that are related to thrombosis or intravascular clotting. They are related to extravascular clotting as well. But if there is no injury, but inside the inflammatory system is going mad, then the platelet increase will cause thrombi or microclots to appear in our vascular system. Many chronic diseases have this pathology. The result will be that small microscopic capillaries will become occluded by these microthrombi. And depending upon which organ, which tissue's blood vessel is damaged or compromised, patient would have outcomes. So that means we cannot say that everyone would have COVID toes, for example, or everyone would have tinnitus. It would really depend which organ got compromised. So first part of interleukin 6. So again, interleukin 6 is trying to do this as a normal thing, and as a normal thing it is useful. But when it becomes abnormal, the same mechanisms, same things would become damaging. The second thing, interleukin 6 came out of the macrophages or dendritic cells and went to the liver. When it went to liver uses that as a message to say, looks like in our body there is an inflammation, there is a war going on somewhere. I need to respond to that war. And how does liver respond to that? Liver does something that is part of innate arm. What it does is it produces certain proteins. These are called acute phase proteins because these are used in the inflammatory process as a disease is occurring. The problem, if liver just continues to make them forever, then although they are acute phase protein, they're supposed to be at the time of the disease, but if liver keeps making them, they would be there forever. That would be a chronic inflammatory state in a person. That will cause chronic issues. So for example, liver would start making C-reactive protein. Liver would start making serum amyloids. These are proteins. It would make fibrinogen. Fibrinogen is used for repairing the area that is getting damaged. It would reduce production of albumin in the presence of interleukin 6. It would increase production of hepcidin. What is if this becomes abnormal? So I'll keep repeating. In a normal case, this is helpful. Help with the war, take care of the virus or pathogen, then repair everything and get out and be done. But when this becomes abnormal, what happens? Now think about it for a second, please. Think about somebody had acute COVID. Then they got long COVID. Now their liver is stuck. Their immune system with liver is stuck in the cycle of chronic inflammation. What is going to happen? Number one, amyloidosis. If we continue to make more amyloid proteins are proteins that would go and get deposited in our tissues. That is like cement or dust or dirt that just goes and deposits everywhere. The result is that when it deposits in the tissues, it hinders with the tissue's functions. It can cause chronic problems that are not fixable because it has damaged the tissues. So amyloidosis can occur. Cardiovascular events, heart damage can occur. Now, when I'm talking about these things, can you connect the dots that many of the current diseases, acute COVID, long COVID, you can actually see these problems in these diseases. You can see or know about these problems in chronic diseases as well. Edema, congestion, swelling, anemia of inflammation. When inflammation occurs, then the anemia because iron starts reducing. Thrombocytosis, as I said above, the platelets are formed and that would cause thrombocytes to be produced. In addition to that, interleukin 6, so we're not talking about naltrexone yet, we're talking about interleukin 6 and its effect. Interleukin 6 works on immune system, adaptive immune system, and creates an imbalance between T helper 17 cells and T regulatory cells. These two cells are usually present in a balance, and their function is to keep the immune system war in a balance. When the war is happening, these two cell types' job is to make sure that the war occurs without getting out of hand, and number two, it finishes in the right time. Inflammation stays there for 4 or 5 days and then inflammation stops. That is a function of these cells. And if you create an abnormality between these cells, if you cause an imbalance between them, what would happen? Immune system will become dysregulated. It will forget how to stop. And that would create a cycle of chronic disease. CD8 cells will increase under the influence of interleukin 6. CD8 cell or cytotoxic cell or killer T cells, their function is to kill other cells which are infected or which are cancerous. So you increase those cells, the damage would increase. That would happen. Antibody production would increase. B cells will be more active. They'll make more antibodies. Now think about it. Somebody who was infected made antibodies, took care of the infection. Antibodies have to then go away. Because when the antibodies continue to stay in our body, antibodies themselves activate the immune system and cause inflammation. Every part of the immune system's function is to cause inflammation. That is the war they are doing. Immune system is not for peace. Immune system is for war. Parts of immune system are for peace, to stop the war. And now if we are making antibodies, antibodies are not only waging a war on the pathogen itself, but they're also activating more immune system. So imagine if our body forgets to stop making antibodies. It is just going to create such a havoc that those antibodies are just continuing to be produced. Inflammation is continuing to happen. Antibody would now cause two problems. One, the antibody would directly attack the tissue. And two, the activated immune system, or as we say, biological functions of the antibody, activation of the complement system, opsonization of the tissues, damage to the tissues where they bind, or damage to the pathogens where they bind. These are physiological functions. And our body would get trapped in inflammation. Then interleukin 6 causes increase in rank L proteins, or ligand for rank production. And so rank receptors are present in the bone cells, and if you produce rank L or the ligand for those receptors, then the bone cells start breaking down, or bone resorption occurs, or osteoclastic activity occurs. And I'll explain that in a bit. That means if you keep having a lot of interleukin 6, by you, I don't mean you, a person. If they keep having a lot of interleukin 6, their bones, their joints would start swelling. They would start having joint pains. They'll start having bone pains, and then they could even start having fractures. That's also under the influence of irregular and continuous production of interleukin 6. So, of course, something should be in your mind, that why the heck will interleukin 6 just stay produced? And we'll talk about that. When the interleukin 6 is produced, it also increases VEGF. And you may have heard the word VEGF so many times from, for example, Dr. Yo. Vascular endothelial growth factor. That causes a number on vessels. That is what its name is, vascular endothelial growth factor. So you start growing vessels in a person's body, the person is in trouble. So these are some of the mechanisms Low dose naltrexone blocks interleukin 6 production and reduces these mechanisms or stops them. In chronic diseases, it can control them. In newly chronic diseases, for example, new COVID, long COVID, it might actually be able to help it to be 100% eradicated. So now look at this, the same mechanism I talked about on the immune chart that we become very used to. This is the dendritic cell, produces interleukin 6. Low dose naltrexone acts on the toll like receptors and blocks them. When it blocks them, so this is not opioid receptor blockade, this is toll like receptor blockade, a very entirely different mechanism. The result is that this immune system cell, the macrophage, the dendritic cell, the monocyte, will not be active or will not be as active. Think about it for a second. The monocytes that are carrying S1 component, according to Bruce Patterson and Dr. Yo's papers, even that monocyte will become cleared out when there is low dose naltrexone, because it would give a break to these cells and say, calm down, you should not become activated. And when they'll calm down, one of the function of the calming down is for them to perish. What a beautiful drug we're looking at. Okay, so this is the action of naltrexone here. Now, if this normal mechanism was continuing, what would happen is, we know that this innate arm will activate the naive T cell, T helper cell. Naive T cell can become T helper 2 or T helper 1. And we know that T helper 2 would then help a B cell to become a plasma cell and make antibodies. We know that, right? We also know that naive T cell under the influence of interleukin 12 can become T helper 1 cell. And T helper 1 cell in turn can activate cytotoxic T cell or CD8. Plus, a naive T cell can actually be converted into a T helper 17 cell or T regulatory cell. So 4 outcomes. This pathway is for humoral response to make antibodies. This pathway is for cytotoxic response. These two guys that are sitting in the center, all happy and dandy, they are responsible to control the immune system and not let it go out of hand. Now let's see. Low dose naltrexone not only works here to calm down, it works in these areas too. How? Interleukin 6 increases T helper 17 cells and creates abnormal immune system persistence that would create chronic diseases. So then the question is, why is it being produced? It is being produced because the whole system falls into a cycle. What is that cycle? This cell got activated, it produced interleukin 6, this system became activated. In that activation, if the interleukin 6 was produced more, abnormally more, or there is a genetic predisposition, or there is a predisposition, let's say because of diabetes or lack of vitamin D's correct levels, what will happen is this guy would become more. When the T helper 17 is more, then this system is now active. What happens is, as a result of continuous activity, this system is going to cause damage to the surrounding cells. Plus, every cell here is going to start producing, majority of them, not every, start producing interleukin 6. Plus, the damaged cell, the tissue cells, have interleukin 6 in them. So when they get damaged, they release interleukin 6. Those cells and production of interleukin 6 does everything that I just talked about. And this cycle just does not stop until you interfere and you say, stop it. How do you interfere? Steroids, anti-inflammatory, and very importantly, low-dose naltrexone. Can you imagine how important LDN is? It's not a baby drug sitting somewhere to say, you know what, it's a fancy drug, just take it. It's a very important drug. Okay, let's see what else does it do. In the bone, so think about patients of COVID, patients of chronic diseases. Their joints are hurting, their bones are hurting, their muscles are hurting. What's going on in the bone? In the bone, so look at this little cell over here, the orangey cell. Imagine that's a bone cell, osteocyte. Inside the bone, there are cells that are called osteoblasts that would make more bone cells, and osteoclasts that would resorb, we call it resorption, that would reduce the bone cells. This is an osteoclast here. Osteoclast's function is to make bone less dense plus remove the bone cells. It causes osteoporosis. Interleukin 6 activates osteoclasts. When the osteoclasts are activated, they would cause bone pain because bones are now becoming weak. But they would not become weak the same day. They would take a few months, few weeks. That is why some long COVID patients would not have problems right away. That is why some chronic fatigue patients are actually feeling okay in the beginning, and then slowly they become more and more um, diseased or ill. Bone pains would start occurring as the bone is becoming osteoporotic. Even fractures would start happening. Joints would start aching. Blood vessel. So I was just talking in FLCCC as well. Imagine this is a blood vessel. All of our tissues have blood vessels, correct? We have blood vessels that start out from heart, and that is one big blood vessel, aorta. Then slowly those blood vessels start dividing, and every time they branch out, they become smaller and smaller and smaller, and eventually they become capillaries. Capillaries are the smallest blood vessel, and the function of the capillary is that it has tiny little gaps in its cells. Through those gaps, nutrients and fluids come out, and through those gaps, fluids go back, and the trash or garbage or the waste products from the tissue, they go back. So that is a very important and a very tight mechanism. If there is any disruption to that, so this is, please pay attention to this, this would actually bind almost all symptoms of chronic disease and the long COVID in this area. Imagine blood vessel becomes stuck in a problem. Imagine there is thrombosis inside this blood vessel. Imagine there is a damage to the blood vessel wall itself. Imagine there are monocytes standing outside that are damaging it. What will happen to this? Imagine there is more interleukin 6 present. What's going to happen? Let's see. This is a poor blood vessel that has become a victim of interleukin 6 production. Under the influence of interleukin 6, a blood vessel starts dilating. So you would say that, so what? Blood vessel dilated. Fine. The problem is when the blood vessel dilates, there is, of course, more blood volume than in that space. When there is more blood volume and the blood vessel is dilated, it also has these gaps between the cells are increased as well. Through those gaps, more fluids come out. More fluids in the tissue spaces would make edema. They would cause congestion. They would cause tissue dysfunction. This is wherever you're sitting right now. Imagine if we fill that room half with water. And we say, whatever you're going to do, you're going to sit here in this water now. So you have to do your functions in that water. You have to walk around in that water. All of a sudden, the whole system is malforming, malfunctioning. So when this congestion occurs, not only there is a pressure produced because of the fluids there, which presses on the tissues and cause them to become dysfunctional, especially in the brain, because brain is enclosed by a bone outside. The skull is outside, brain is inside. The other such place is chest. The bones are outside and the tissue is inside. I said for the brain, the skull is outside and the skull is outside and the brain is inside, correct? So when there is more pressure in the brain has no space to swell up. And so from outside, the bone is pressing in, and from inside, the fluids are pressing out, and the poor brain becomes sandwiched between those pressures and becomes dysfunctional. If it is joint spaces, swelling would occur, pains would occur. Now, in addition to dilated blood vessel, interleukin 6 also causes production of VEGF. You would hear that a lot from Dr. Yo and Dr. Bruce, um, that Patterson, that there is a lot of VEGF produced, vascular endothelial growth factor. Its function is to increase the branches from a vessel. Normally, it is a useful thing if it happens physiological. For example, let's say somebody's heart blood vessels are occluded. Not fully, but the blood to the heart tissue is reduced. To compensate for that, it is possible that the new branches from the blood vessels will form and they'll start going to the tissues where more fluids and more nutrition is needed, and the original vessel is not able to bring that nutrition to them. So that's a good thing. Imagine if some tissue is broken and new tissue is now being formed. Let's say the lung damage occurs because of SARS-CoV-2, and now the lung repair is occurring. We need to form new blood vessels. So forming new blood vessels is not a bad thing in a normal circumstance. But forming a new blood vessel is abnormal if it is not needed and we are making it. That is what happens when interleukin 6 is present. It produces VEGF, or it triggers the production of VEGF. VEGF in turn causes, see these branches on this blood vessel? It makes new branches. That is what endothelial growth factor means. Now, when those new branches are formed, in the beginning, these are like naive new branches. These are new little pipes that are being built. So they're leaky. They're not mature yet. They're leaky. So they would start leaking the fluids out of them as well. Plus, when you produce too many blood vessels, that area will become permanently engorged with blood, or edematous, or inflamed, or congested. Now, problem is, once these blood vessel branches are produced, they cannot go away. These are microscopic things. We cannot take a scissor and, like a tree, go and trim them. They are there now. And if that is causing congestion in that tissue, then we have congestion now continuing. This also tells you how important it is that after the triggering factor for a chronic disease, soon after that, we control the cycle of inflammation and break it right away. Because if we don't do that, then some permanent damages can occur. So this would cause edema in the tissue, swelling, pain, angiogenesis, unwanted blood vessels would start forming, joint swellings would occur, which would then cause joint pains and so on. Similar problem with the skin as well. So in our tissues, almost all of our tissues, we have fibroblasts. Fibroblasts are these green cells I've made over here. Their function is to make fiber, not the fiber that we eat. The fiber for our body is collagen and fibrin and so on. They make collagen. Interleukin 6 triggers the fibroblasts, increases them, proliferates them, makes them active. The result is they start making a lot of collagen. That lots of collagen starts getting deposited under the skin. That would cause rough skin, less functional skin, and that would cause thickening of the skin. So now we have collagen and fibrosis. And when we have low dose naltrexone, that is going to break this part of the cycle as well. So now think about it, how many problems of a chronic disease are kind of managed or handled by low dose naltrexone. There can be a possibility of tinnitus, which is because of vascular irregularity. It may be congestion because of the vascular problems, or it may be microthrombi reducing the blood nutritional substances going to the inner ear, causing tinnitus. LDN would help with both because it would reduce the platelets. It would help reduce microthrombi. Because it would reduce interleukin 6, it would help reduce the vascular congestion and the neovascularization or production of new blood vessels. Neurological symptoms. One, it actually directly works on the brain tissue, works with the opioid receptors, helps produce endorphins that creates relaxation, that also cause immune system modulation towards a better immune responses. In addition to that, it reduces congestion. It also breaks the cycle of interleukin 6 in the brain tissue as well. So you can see the whole system. Joint pain would be handled by it. This cycle of inflammation and chronic disease would be broken in general by it. So I think it is interesting to consider LDN after every COVID or in the beginning of any chronic disease where a doctor or a physician, so of course, this is not a medical advice, is not a therapy, this is not a prescription. This is really informational. So if a doctor is listening and they think that, hey, I need to, I have, let's say, Lyme or other things, and I can suspect when somebody might end up having it, it may be useful to try low dose naltrexone right in the beginning with steroids, for example, to help break the cycle that can then become permanent if not broken in time. This is why it is actually used for chronic diseases, low dose naltrexone. It is also used for chronic autoimmune diseases because it breaks the cycle of autoimmune behavior. It is used for cancers because it reduces cell growth. And one more thing, last points, and then we stop with this talk. Low dose naltrexone is really 0.5 to 4.5 milligram. People have been giving up to 10 milligram, but really 0.5 to 4.5 has been studied in the studies. As the dose increases, this effect of low dose naltrexone on the immune system actually reduces, and the effect starts becoming predominantly opioid receptor antagonism and help with the addiction. So as a doctor, you should not look at it to say, oh, well, it is working very good for a patient, why not increase the dose? The rules for the low doses, it is given, for example, for Hashimoto's thyroiditis, it is given for multiple sclerosis, it is given for other autoimmune diseases as well, it is given for chronic fatigue syndrome, it is given for fibromyalgia, and so on. Usually 0.5 or 1.5 milligram per day at bedtime is something that is used. If after a week's usage, and please remember, the patient doesn't start having the effect right away, because what do we need? We have to break the interleukin cycle, and the dose is really micro dose. So we have to break the interleukin cycle. Then we have to allow the tissues to become cleared out. It is not a one day thing that you give it today and tomorrow the patient is fine. It takes weeks to months. This is why it is important to continue with this one. So what happens is, after a week, if the patient is not responding, then 1.5 milligram can be made 3 milligram. If patient is responding, then this dose should be maintained. If patient is getting side effects, the side effects can be insomnia, vivid dreams, GIT, upset, but it is usually such a low dose that it doesn't cause a lot of problems. But let's say if that happens, then instead of stopping the drug, you can reduce the dose to half, because usually the side effects after a week's administration, side effects go away. So what you have to do is you have to continue the body to be exposed to LDN by reducing the dose to half, and then waiting for a week. If it still has the side effect, reduce it further. Usually by this time the side effects have gone, and then you can escalate the dose again. Now, there are some serious outcomes that can happen as well. For example, if somebody is on autoimmune disease management, they are already taking immunomodulators. You add LDN, and it is possible that their immune system drugs need to be adjusted, or immune system can become further disorganized. Similarly, if somebody is on Hashimoto's management, you give them LDN. LDN would change immune system's behavior. Their thyroid levels would become different. You have to now titrate the remaining drugs as well. Same for multiple sclerosis. Same for fibromyalgia. So that means that when if people are, and especially if somebody is already taking opioids or opioid drugs, they need to stop them before starting LDN or taper them down before starting it. And similarly, if somebody is taking those drugs, then giving low dose naltrexone can actually cause a counter to the drug, and that has to be made sure that patient can take it. Similarly, if somebody is going to have a surgery and they're going to get anesthesia and then painkillers, LDN's usage may have to be stopped. So you can read that up in LDN. The point is, it is not just something you start today and you stop tomorrow. Usually, you start it continues on for some time, produces its effect, breaks the chronic inflammatory cycle. Fortunately, for many patients who may have long COVID, they are in the beginning of it. Trying this drug can actually help. But once again, this is not a medical advice, this is informational. So, this is the discussion for the LDN. I have not talked about the um, neurological or the opioid receptor related functions. We can talk about that at some other time. This was more of an immune modulation through blocking the toll like receptors and reducing the interleukin 6. One thing I forgot to say, nuclear factor K beta or kappa B is inside the cell a mechanism for responding to inflammatory cytokines. All cells have it. LDN suppresses that too. You know, there is another drug that does it, IVM. You know that vitamin D does that too. You know that there are many other immunomodulators that do. This does that too. So it helps. So this is where we are at with this. Please like, subscribe, and share. If you would like to support this work as well, there are links in the description. You can buy me a coffee or you can become a patron, which I prefer if you become a patron, even if it is $5 per month, because that would allow me to continue making these lectures, not just for COVID, but other things too. And you can use PayPal as well. With this, thank you very much. I'm going to see you in a few minutes. Totally different topic, and that is FDA's urging of the Pfizer to apply for kids vaccine. So I'll see you in a few minutes. Thank you. Bye bye.